Welcome back, everyone. And now we have closing remarks from Will Lightbourne, the Director of Department of Healthcare Services, and a fitting end for a day that started in the community, heard family voices, youth voices, and some remarkable education program with disconnected youth. And Will, welcome.
Thanks, Steve. It's a pleasure to have the opportunity to share some thoughts with the Breaking Down Barriers Symposium group. Just a little bit of sort of personal background. Although most of my sort of professional life has been spent in the social services side of health and human services, the moment that we're in represents, I think, a really appropriate opportunity to engage health thought broadly, as well as social care in its best sense. The events of the last mostly year, I suppose, have illustrated probably more vividly to the country as a whole the degree of disparities and inequities that low-income people, and particularly low-income communities of color, have been enduring for eons. I said to people, the COVID pandemic landed on top of an economic crisis pandemic that landed on top of, or was rooted in, a pandemic of racism. And we now have to look at how our various institutions, social, health, economic, housing, are brought to bear in a laser focus to address issues of equity. As director of DHCS, the basic tool that we have is the Medicaid program, Medi-Cal in California. It's, in any given year, we probably are spending somewhere between 110 and 115 billion dollars in healthcare funds to provide care for low-income people in the state. And that's, when we think about it, that's an immense resource that we need now to sort of always look at with the eyes of how can it improve social equity, how can it diminish systemic oppression in our communities. And by doing that, we don't just think of it in terms of health in a clinical sense, but health in a whole person sense, a sense of behavioral health, a sense of social health, and a sense of community health. This isn't something new to us. California, to its credit, over the past 10 years, has led the country in expanding Medicaid coverage. After the passage of the Affordable Care Act, California expanded Medicaid faster and further to the allowable limits of the program than any other state in the country. Nearly 5 years ago, we became the largest state in the nation to provide full scope Medi-Cal for youth, regardless of their immigration status. And in January, we extended that to youth up to age 26. Now, approximately 40% of the people covered by Medicaid is made up of children. And in fact, let me reverse that figure. 40% of the children in the state are covered by the state's Medicaid program. What we saw, I think, in the COVID pandemic was a disruption to social patterns, a disruption to family patterns, a disruption to economic patterns, the consequences of which I don't think we will know for years to come. It did, however, in the field of healthcare, to some extent, accelerate new approaches. And some of those are things that we will definitely seek to continue because they probably have helped increase people's access to care, through telehealth and through telephonic medical services being provided that I think have been useful, particularly with younger communities in increasing access to care, but also in terms of making behavioral health more accessible in many instances. So there are aspects to that we'll be seeking to continue. Additionally, Department of Healthcare Services was able to obtain some significant FEMA funding for the Cal Hope program, which is now a sort of a online warm line mental health service system available statewide to all in need. So those are the short-term takeaways that I think from transformation to the delivery system, we'll see that sort of are on the natural. The rest, though, the transformations we need to make are things we're going to have to, in a sense, force. We're going to have to get there through deliberate planning and deliberate views. And let me sort of highlight some of what I think are the most important areas to hang on to. It used to be that we would think of chronic health conditions as primarily being something that affected adults. And in fact, in recent times, the pattern has shifted. Children are increasingly vulnerable to otherwise preventable or treatable diseases and disabilities. And this is sort of something that has become apparent over the last several decades. And so we've been sort of deliberately trying to force a shift in emphasis to stress things like immunizations, blood lead screenings, developmental and behavioral healthcare screenings. An area that is relatively new, but is something which we've been embracing with a great deal of energy of late, is in partnership with the new, for California's Surgeon General's office, is adverse childhood experience screening. What we're doing starting this past year is we've begun to literally pay providers, healthcare providers, to screen both children as well as adults for ACEs, and then refer them as necessary for sort of services that can help mitigate the experience. As we know, people with a cumulative ACEs score in excess of 4 are highly likely to have both physical and behavioral health consequences that are negative. And so among those things that create that dynamic are circumstances that frequently occur in communities that are low income and in particularly low income communities of color. Issues of poverty, of substandard housing, of exposure to official violence. All of these are things that weigh on the health, the long-term, lifelong health of people, and starting as children. And so the ability to address those, I think, is an important step forward for the state. The effective use of our EPSDT program is something that we are determined to emphasize going forward, and to monitor to make sure that all children and youth covered in the Medicaid program are receiving the preventive and screening services and the treatment services that they need. But primarily, what I wanted to spend a bit of time on today was to focus in on the health equity dimension, and recognizing, to start with, that health outcomes are not just a result of clinical services. There's an estimate, and I don't know how scientific it is, but an estimate that says health outcomes are 20% the result of clinical interventions, the services that the doctor provides, and 80% the result of the social environment in which the person is growing up and living and working and trying to support family life. And when we look at the health outcomes of people in our systems, what we observe overwhelmingly are the negative outcomes that occur with communities of color. People have noted that with the COVID pandemic, the likelihood of contracting the disease is far higher for Latino communities, and the fatality rate, having contracted the disease, is far higher for Black and Latino communities. This is not because they don't get care. This is even after receiving care. And the only obviously answer is the care is not equal. The care is relative to what other people will receive when they become ill, is substandard. And that is something that we have to make a sort of a fundamental commitment to change. We capture data from our providers and from our health plans about these outcomes, and we've been issuing an annual health disparity report that illustrates the differences. What we have not done as energetically yet is take the next steps in saying what actions have to occur to change those inequitable outcomes. And that's what we're really going to focus the next years of Medi-Cal health policy in California to do. We've begun a sort of an annual health equity award for our Medi-Cal managed care plans that demonstrate exemplary efforts to reduce disparities. This year, 2 managed care plans tied as the Health Equity Award winner, one for doing a doula pilot project. And the importance of that, just as a pilot, is that the maternal health outcomes for African Americans is much worse than for all other groups. And the acceptance and the utilization of doula-type services is much more sought in that community. So for Anthem Blue Cross, they took the step, and we commend them, of offering doula services as a pilot program. Scan Health Plan developed an insulin advisor service. The importance of that being, when we look at disparate health outcomes in different ethnic groups, diabetes is a major source of illness and preventable early death in both African American and Latino communities. And so these are small examples of the way practice changes can affect outcomes. One of the things that a third plan did, and I want to emphasize this, is develop a transitions program for people recently released from incarceration. And if one thinks of sort of the overall sort of soup of causes that are so destructive to low-income communities and communities of color, the high rates of over-policing, the high rates of police violence, the high rates of mass incarceration, the high rates of absence of usually male figures. And so the importance of stressing re-entry and de-emphasizing incarceration becomes critical. One of the things that I am hopeful that we will have room to work with the new Biden presidency is changing the underlying Medicaid rules that make it very difficult to provide behavioral health care services in locked environments. We want to be able to start treating people as soon as we can identify their needs and not wait for them to move into community without support. But most important is reversing the pattern of when we serve people. Far too much when we look at when people are actually receiving, particularly behavioral health services, we can see what looks like high take-up rates. And then when we look at where that take-up occurs, it's in emergency settings, it's in institutional settings, it's in incarcerated settings, as opposed to in community, in home, in clinics, in the settings that are likely to prevent ultimately the worst kinds of possible outcomes that will occur. What's next as we try to move into a whole person care environment? One of the things that we have done in the area of services for children with special needs is sort of created a whole child model system of care, which is still in a exploratory stage. We'll be evaluating it closely, but the intent there is to make sure that those children who were previously sort of in a county CCS service environment now can be integrated into a holistic health environment, so that as they age, they don't have to transition away from systems of care. Similarly, for adults, the state developed the whole person care model of services that for the most people with the most acute needs integrated physical health, behavioral health, social services, and under the COVID epidemic, housing services to try to wrap around people. And that, I think, points to where we overall want to go in healthcare in California. DHCS had developed a proposal for implementation that was called CalAIM. And the whole purpose of CalAIM is to integrate physical healthcare, behavioral healthcare, and attach to them enhanced care management and fund in lieu of services, non-clinical services, but the sorts of housing-related, hunger-related, effective living-related services that, if provided, would likely be the factor that changed health outcomes along with the clinical services. That implementation got delayed because of the COVID epidemic, but it remains our sort of burning light that we're heading towards. We hope that in the year ahead, we'll actually be able to start implementing the whole CalAIM system of service. And the real intent there is to move from a system that is treating illness to a system that seeks to build wellness, that puts great emphasis on preventive services, and that looks at the whole person need and where that whole person need requires services outside of the traditional health system. Partner with community organizations, social service agencies, housing agencies to complete the package that will help people live healthy lives, well lives. The specific component of it also is to expand the suite and the reach of home and community-based services for people aging or living with disabilities, so that the sorts of services that can make it possible for people to remain in their own homes, in their own communities, away from institutional life, are fully available. And so with luck, we expect to be able to start to roll these services out in the next year and two ahead, and begin full implementation there. The other aspect that runs alongside this, and that I want to emphasize, is we are beginning the process right now of what we call reprocuring the managed care plans that receive funding from Medicaid from our department, to contract with providers and clinics to deliver services. In the past, we've really never had a one-time procurement of these programs. They've been added over time as managed care has expanded from one jurisdiction to the next. And at this point, we think it is time to step back and say, no, at one time, we want to go out and reprocure the commercial plans, not the county-operated plans, but the commercial plans, to really state a set of goals that we expect them to achieve. First among those is going to be quality. We want to be sure that high-quality services are going to be delivered to everyone receiving Medicaid services in California. It is an embarrassment to the state that, on average, the consumer satisfaction ratings in California in Medicaid for managed care fall below the national averages. That's not good enough, and we're going to insist on high quality. And we're going to move the payment structure to reward high quality. Secondly, they must address disparities, racial disparities in outcomes. And they must demonstrate how they're going to do it. And then they will be reimbursed according to the progress they make towards those goals. We have to, as a state, as a public, use our purchasing power to get the goals we need and want, not the goals we've been, or the outcomes we've been getting. The third thing that they are going to have to satisfy us that is that they truly can access all parts of the state. We need, the term in the business is network adequacy, but we really have to be at a place where every part of the state is getting high quality services and there is good access, particularly with the advances that we've made in telehealth. There's really no excuse why any community should be beyond the reach of high quality healthcare services. And the fourth thing that we're going to look at them to deliver on is integrating those social determinants of health, the social care components, into their overall delivery of health care. We need to have a broader understanding of healthcare in California than we've historically had. And we have to realize that people cannot be healthy if their community isn't healthy. And the community can't be healthy if it is the victim of continuous discrimination or oppression. And so, in partnership with the non-health systems of the state, the other part of the agenda that we will be working towards is how do we lift those conditions of oppression, the interlocking conditions of oppression, racism, patriarchalism, violent policing, what I think of as racialized capitalism. How do we reform those to a state that we have good investment in our communities, good community health, and therefore good health for the people of our state? So thank you. It's a pleasure spending some time with you.
Thank you, Will. You certainly outlined a ambitious and critically needed roadmap for where we're going. And I can't think of anybody else whose background and commitment is better than yours to lead this. So I think I speak on all of behalf of Breaking Barriers stakeholders. We look forward to working with you to make that happen, because that's clearly what we've been about as well, in a smaller circumstance, but yours is the broader and the more important one. There haven't been any questions, which I'm surprised. And yet I want to say thank you for everyone. I have a hunch yours is going to be one of the more downloaded recordings going forward to make sure they got all your nuance. And with that, I just want to let everybody know to please complete your evaluations. Know that all the recordings will be up as of tomorrow. Jamie always does a great job in getting those out. And please be prepared for next week when we do finance and shared resources. So again, stay well, be safe, and we look forward to an ongoing dialogue and what we're going to begin to create together next year. Be well.